This is an insight clip from the Dr. Geo Prostate podcast. In this segment, Dr. Gong breaks down glutamine, ADT, and aggressive prostate cancer, and the latest clinical trials redefining ADT strategy in advanced prostate cancer. Catch the full discussion in episode 128. Let's get into it.
What's being studied that you think will have legs eventually, particularly in men with advanced prostate cancer? Is there anything out there that it's being studied that you say, I think hopefully, again, I won't hold you to anything. I know how strict you are to the actual science, and I appreciate that. But what's out there right now? What's being studied?
I think the exciting areas in prostate cancer specifically, I think neuroendocrine prostate cancer has really shown to be among the most glutamine addicted types of cancers here. And that's a high unmet need population there. So I think there is a lot of exploration. Can we use that as a signal, as a biomarker that, hey, these patients are at risk for transforming into these aggressive subtypes, and then ways to treat them? In the other topic that has been really exciting to us, at least, Doctors Bolmick and Dr. Posadas, who are all my colleagues here at Cedars, they published a paper a couple of years ago that showed that the potential source of glutamine that is increasingly being used by the prostate cancer cells is actually maybe coming from the tumor microenvironment. These are called stromal fibroblasts. These are the support structure cells around that support the prostate cancer cells. And this paper, which was published in JCI, it's very fascinating. They showed that it wasn't until you were exposed to androgen therapy, androgen deprivation therapy, that you then upregulated the pathways in the fibroblasts. And they took proteins from the environment, albumin, you name it, through a process called macropinocytosis. And they took that in and they released glutamine that was then used by the adjacent prostate cancer epithelial cells. So that I think that was so that opens a whole new avenue of, I think, maybe leading to your original question of how do we block this pathway in a safe way, because there is nutritional benefits of glutamine as well. I think our group is saying you got to look at the stroma too. What's feeding the prostate cancer cells. It may not just be them sucking it up from your diet. It's something happening from another player that's and then our treatment may be triggering as well. But that's a very complex question. I'm not going to say androgen deprivation therapy is bad for us. It's just
no. But here's where I'm going with this. With my patients on ADT, okay? So understand, my patients see me for two reasons. Number one, I'm sort of their prostate cancer navigator. Hey, I have this, that. What do you think I should do? Even from a medical standpoint. And then what are the natural and lifestyle approaches? With my ADT patients, I have two goals. Number one, reduce the side effects of the ADT as it relates to metabolic syndrome, cognitive decline, pretty much everything except sexual function, because I think is very difficult and I don't have an answer for that. Number two, prevent castrate-resistant disease at all costs if I can. So the conversation that we talk about is, okay, so I went to Dr. G, I went to my oncologist, they put me on Lupron. And I'm saying, all right, good. Now, when are they going to put you off Lupron? What's their cutoff point where it's, okay, a year with an undetectable PSA, okay, let's get you off and let's give you a break. Let's do it intermittently, because we want to avoid, by all means, castrate-resistant prostate cancer. And you're mentioning one of the pathways related to glutamine. And this is why I kind of cut you off. And I was like, look, as a scientist, I'm not a scientist. I'm a practitioner. I'm a clinician. I get excited. You're not supposed to be excited, right? You're supposed to kind of even keel. Don't get too excited over conclusions or results. But, I'm a human and I want to see patients do very well. So to give me some guidance, wow, there's a glutamine pathway when cancer becomes resistant that may promote the aggressiveness of prostate cancer. This is, for me, is beautiful, because this is what I'm trying to do here. I don't want them to get resistant to the disease. For the audience, we spoke a lot, and I don't think many of them know what neuroendocrine is. Neuroendocrine, and June, I'll let you chime in as well, because I'm going to summarize. Neuroendocrine is a more advanced disease that typically, in my experience, is found when the PSA is actually low, not high. There's a low PSA. Sometimes I've seen patients with a PSA less than 1 with very aggressive disease. Now, that's probably, if I remember correctly, no more than 2% of the population with prostate cancer who have a low PSA and aggressive cancer, or they had prostate cancer, was treated, and now it became a neuroendocrine disease with time, where that means it's very aggressive and it typically spreads beyond the bone quickly to soft tissue like lung tissue and brain. Is that pretty much right, June?
That is absolutely correct. And it behaves differently from what we've known of classical prostate cancer. Like you said, it's not PSA secreting. It's learned its way to not be androgen dependent. And I think that's where the unusual metabolic dependencies you've hinted at, it becomes more glucose dependent and more glutamine dependent, hence where FDG PETs can pick up neuroendocrine prostate cancer. It's like a different entity that's very aggressive. And you're right, it is often therapy induced eventually through resistance pathways.
I've had Alicia Morgan on, medical oncologist from initially Northwestern, now she's at Harvard. And our conversation was around intermittent ADT. And I raised a provocative question. I wonder what your vision is or what you think of this. When there's a recurrence of prostate cancer after treatment, we don't know exactly when to pull the trigger and get them on ADT. We're just PSA dependent. And if it starts inching up, it's like, oh, right away, let's get them back on ADT. I don't know about that. But I also don't know when you do pull the trigger. You know, I always say to patients, I don't know, but it's not 0.2. I don't know, 0.5. I mean, there's some ambiguity here, and you have to, depends on your risk tolerance and your conversations with your oncologist. What are your thoughts on when, so there's a recurrence, they had a prostatectomy, radiation, it's a recurrence. Well, the PSA situation is a little bit different. So let's just stick with, they had their prostate removed and now their PSA is rising and they had radiation and then it's still rising. So there's a recurrence. When would you say, all right, now you need to be back on ADT, including patients that I have on ADT who they get off of it 6 months later, starts inching up, whatever the number is, 0.2, then it goes 0.3, 0.5. And I'm like, okay, maybe we can wait till it's 1.0, like, or wait until something comes up on a scan. So what are your thoughts? What would you, and if there's any research, please let me know. I don't know of it. And what would you do in that scenario as a clinician? What would you advise?
Well, I think this is where Dr. Friedland would be a nice conversation piece here because of his recent positive trial on the Embark study. I think they provided a little bit more, they shed some insight into the patient populations where these are high risk for recurrence now after definitive therapies, and the Gleason scores, the tumor histology from surgery, these are features that can help predict which patients to get on. But I think they've most importantly given us insight on possibilities of when to stop. So on the Embark study, if you reach the PSA threshold by, don't quote me exactly, about 30 months or so, then you can stop. And that, I think that was wonderful for them to answer when to start, not the populations to start, but also when to stop. In the high risk setting. In the metastatic setting, you're right, we don't have really clear evidence. The convention has been you put patients on indefinitely on ADT, and patients, it's a big quality of life impact. But I think we are recognizing that as a field, and we're trying to answer these questions now. So I'm aware at least of one study. It's an ongoing study. It's a phase 3 Libertas study. Libertas, Libertas. It's ongoing. It's metastatic prostate cancer patients. They're randomized to, I think, what happens is they get Erlita, which is one of the ARSIs, plus Lupron. Mm-hmm. And if they, after 6 months of therapy, if they reach a nice PSA response, this is where the study seeks to answer that question. They randomize them into intermittent ADT at that point, or the standard continuous ADT. I think the field is responding and they're listening, and they feel like we need evidence to guide our providers of when to stop Lupron or ADT in general.
Thanks for watching. Catch the full episode on the Dr. Geo Prostate podcast. Don't forget to subscribe and hit the bell so you never miss our next insight. We're honored to be part of your prostate health journey.